Welcome you all to this academic session. I want to introduce our guest faculty for today's session, Dr. Venkat Sripathi sir. Sir is a senior consultant pediatric urologist and robotic surgeon from Apollo Hospital, Chennai. Sir has one of the highest and most diverse experience in pediatric robotic surgery in India. And he's also heading Director Fellowship Program at Apollo Hospital, Chennai. Sir has also published many papers at around 60. Sir has around 60 publications. Sir, we welcome you, sir, to this case presentation.
Thank you.
Sir, I'm proceeding to the case. I'm Dr. Sukumar, final year postgraduate from Nilofer Hospital, sir. So,
please,
yes,
go ahead, Sukumar. Yeah.
So, I'm presenting a case. Baby name is Baby of Lakshmi. Is a male child of 3 months age, sir. Is a resident of Nizamabad, and the informant is mother, and she is a reliable informant. He came to the hospital with mother's antenatal ultrasound report suggestive of left hydronephrosis. And the baby doesn't have any history of any fever, excessive cry while passing urine, or frequency, hematuria, or dribbling of urine. There is no history of any excessive cry with abdominal swelling followed by passage of large quantity of urine. There is no history of any refusal of feeds, loss of weight, and failure to thrive.
Yes, sir. Yes, sir. So basically, you're talking of an antenatal hydronephrosis,
yes, sir.
Antenatally diagnosed hydronephrosis, and the postnatal follow-up.
Yes, sir.
Okay.
Yes.
Now, this history of excessive cry with abdominal swelling followed by the passage of large quantity of urine.
Yes, sir.
What exactly are you trying to tell us when you say that?
Dietyl's crisis, sir.
Okay. Okay.
There is a huge hydronephrosis.
Correct.
So child will have a severe pain with abdominal swelling. Then child will pass large bouts of urine. After that, the swelling will reduce, sir.
Okay.
It's called Dietyl's crisis.
My question to you is,
yes,
how common is Dietyl's crisis?
In infants, it is very less common, sir.
Yeah. So my suggestion again,
okay,
a little bit about Dietyl's crisis. Is it one kidney or both kidneys that are affected in Dietyl's crisis?
Sir, one kidney, sir, which is obstructed kidney, sir.
Correct. Surprisingly, when Dietyl first described it, it was bilateral hydronephrosis. But then we are applying it only to one side. But be that as it may, it is not something that you would mention when you're talking about a baby who's presenting with hydronephrosis at 3 months on an antenatal history. I personally would not talk about that.
Okay.
Because it will sort of, what really happens is you're leading the examiner to get into an area.
Okay.
Okay. We'll talk about that later. All right.
Okay.
No problem.
Coming to the antenatal history, the parents has non-consanguineous marriage and antenatal registered. They had an antenatal scan done in 3rd trimester, which was showing left moderate hydronephrosis, and the anterior-posterior diameter was 10 mm, and there is no oligohydramnios. Hello, sir. I'm audible, sir. Hello.
Yeah.
Sukumar, go slow.
I'm able to hear you.
Yes, sir. So, and coming to the antenatal history, the parents are non-consanguineous marriage. The mother was antenatally registered. The antenatal scan was done in 3rd trimester, which was showing left moderate hydronephrosis, and the anterior-posterior diameter was 10 mm.
Okay.
There is no oligohydramnios.
Okay.
Coming to the perinatal history, the birth order of the child is 2, is a term delivered by segment cesarean section, cried immediately after birth, and the birth weight was 2.9 kgs, and the child was exclusively breastfed, and the child was immunized up to date as per schedule. There is no significant treatment history. There is no significant family history.
Okay. So this is it okay, Dr. Narendra, if I sort of discuss each slide as he's putting it up? Is that okay with you?
Yeah. That's okay. What we want, sir.
I'll put a question to you.
Yes, sir.
Let us say these people are, they are very intelligent, and they come to you with this antenatal scan, which has been done in 3rd trimester. When you say 3rd trimester, which gestational week are you talking about?
This is in the third trimester, sir.
Okay, so if we don't have a gestational week, let us assume it is third trimester, no problem at all.
Yes, sir.
Okay, now you have told me there is moderate hydronephrosis and the APD is 10 millimeters. Now, if they come to you with an antenatal diagnosis like this, how are you going to counsel them? Tell me, just treat me as if I'm the parent and tell me. I'm
Yes.
telling you, doctor, I'm really worried, please tell me.
Yes, sir. Actually, when the mother comes with the antenatal scans as to hydronephrosis, we have to grade the severity of the hydronephrosis, sir. So it
Very
is,
good.
if it is in the third trimester, the mild is like less than mild is 7 to 9 mm, sir. Moderate is 10 to 15 mm, sir,
Very
and
good.
severe is greater than 15 mm, sir. So
Okay,
it
what
comes under
classification
moderate.
is this?
Sir, is a SFU grading of anterior posterior diameter, sir.
You're talking of SFU grading. Is there
Yes, sir.
another name for this now rather than hydronephrosis today? Okay, now the term hydronephrosis has been given up. What we are talking about now is called urinary tract dilatation or
UTD, sir.
UTD.
Okay, sir.
Okay,
Urinary tract dilatation.
you're talking about urinary tract dilatation. Okay, urinary tract dilatation. Yes.
So according to this, it comes into moderate. Anything when the APD is greater than 10 mm, there is around 30 to 50% chances that postnatally the child may have persistent hydronephrosis, sir.
Now, 10 millimeters has come. I've come to you with 10 millimeters. Now, I am worried. I'm going to ask you, what do you think? Should I terminate the baby, sir?
No, sir. No need to
Okay.
terminate a baby, sir.
Okay.
We can proceed with the pregnancy, sir, and we have to follow up postnatally, sir.
Okay. According to the UTD grading, what grading is this? Can you put a number on that?
This is UTD A1, sir.
It is a UTD A1. Now you are coming to business. When you say UTD A1, you are essentially talking only about hydronephrosis without peripheral calicial dilatation. Am I correct?
Yes, yes, sir.
Okay. Which means when you're talking about UTD A1 without peripheral calicial dilatation, now why I'm telling you this antenatal scan that you're talking about is an extremely important thing.
Yes, sir.
You have to talk about renal parenchyma. Is the renal parenchyma normal?
Sir, actually it was not mentioned in the scan, sir.
Okay, fair enough, fair enough, fair enough. So when you look at a UTD classification, you have to look at renal parenchyma, which means what all things will you look at in the renal parenchyma? On an antenatal scan in the third trimester.
Sir, in renal parenchyma, we have to see the echogenicity of the renal parenchyma and the
Excellent. When you
thickness of
say,
the
yeah, when
thickness
you
of the
say, very good, very good.
thickness of the
Thickness of the renal
parenchyma and
parenchyma and
any
echogenicity of the renal parenchyma.
parenchyma, sir.
Okay, when you say echogenicity of the renal parenchyma, what exactly are you talking?
When there is renal dysplasia, there is increase in echogenicity of the renal parenchyma, sir.
What exactly does echogenicity represent when you do an ultrasound? How do you compare echogenicity of the kidney in a fetus?
Opposite kidneys.
Yes, and
Any solid organ?
Liver.
yes,
Liver.
you compare it with the liver or
Liver,
spleen.
sir.
Very good. I'm very happy
Yeah.
you picked up the clue. You compare it with the liver or spleen. If it is as bright as the liver or the spleen, then this is an echogenic kidney. Okay, now you're doing extremely well. I'm going to ask you a question to give you a prize. Let us say, what exactly in ultrasound terms does the echogenicity represent? When you say echogenicity, what exactly does it mean in ultrasound terms?
There is dilatation of the
No.
No.
Echogenicity.
Just the word echogenicity. What does it represent in ultrasound terms? We're talking about ultrasound.
Which are given, how much it is received back, sir.
Excellent, excellent. So it represents an interface. That interface is a urine tissue interface.
okay, sir.
The more urine tissue interface you have, which in other words, the more dilated tubules you have, the more dilated collecting ducts you have, the more echogenic it is. Do you understand?
Yes, sir.
Okay. So it's a reflection. It's the reflection of the amount of urine tissue interface that you have. Okay. What else will you see in the parenchyma?
Any presence of cysts, sir. Cortical cysts.
Excellent. Excellent. So cortical cysts are very important. Why are cortical cysts important?
Severe form of dysplasia, sir.
Okay. It's a severe form. You have used the word dysplasia quite a lot. Now, having told me dysplasia some 2 or 3 times, I'm going to ask you, what is the histological criteria of dysplasia? Are you aware? When you use the word dysplasia, so the word dysplasia essentially means primitive
Primitive
glomeruli,
cells. Yes.
and also means tubules that have a fibromuscular collar around. That's what dysplasia means.
Okay.
Now, why I'm telling all of you this, all of you listening to this, you must understand that antenatal scan essentially involves you looking into every one of this. The most important thing as far as antenatal scan is concerned, you still haven't told. Renal length.
Okay.
Yeah, so renal length is also important, isn't it? So you have to measure the renal length. In a unilateral hydronephrosis, you can compare it to the opposite side. So you've looked at renal length, you have looked at AP diameter of the pelvis, which is the least important, I feel. Then the parenchymal echogenicity, you have looked at parenchymal cystic changes. Anything else? Anything else?
We can we have to see for the lower urinary tracts.
Very good. You have to look for the lower urinary tract. What exactly are you looking for?
So I'm looking for the bladder, any thickening of the bladder or dilatation of the bladder, or any ureteric dilatation.
Any ureteric dilatation.
Ureteric
dilatation. Suppose I tell you that the ureteric dilatation is the ureter seen in its entire length. What do you think it represents?
Is it abnormal or normal?
So actually, ureter will not be visible, sir. When it is visible, it is dilated, sir.
Excellent. Yeah, excellent. So what does it represent? As the father, I'm telling you, doctor, they've written something about one tube being seen. What do you think I can expect when the baby is born?
If it is unilateral,
Yes.
if it is bilateral, we can suspect a bladder outlet obstruction, sir. If it is a unilateral,
unilateral. Yeah.
Maybe a VUJ obstruction.
Yeah, possibly obstructive megaureter. Absolutely right. Absolutely right. Let us say that the ultrasonologist says there is intermittent ureteric dilatation. Sometimes they're able to see during screening, sometimes they are not. What are they talking about?
Something is going through that.
So when there is intermittent ureteric dilatation, the possibility of it being reflux is quite high. Okay?
Okay, sir.
Okay. Now, you brought up the term obstructive uropathy with regard to the bladder, and you spoke about bladder wall thickening.
Yes,
now,
sir.
As a clinician, I want one clinching sign or documentation that will tell me this baby has a PUD.
Keyhole sign, sir.
Yeah, okay, keyhole sign. Anything else? I'm talking of a dynamic oligohydramnios. What exactly do you mean by the term oligohydramnios?
When the amniotic fluid is less than 200 ml or the amniotic fluid index is less than 5, sir.
Okay.
Because there is bladder
amniotic fluid
obstruction.
Index is less than 5.
Yes.
How do you calculate amniotic?
Sir, it's a 4 deep pockets. Average of the 4 deep pockets in the amniotic fluids. Hello, sir.
Okay. You should have a minimum of how much in each pocket? You must have a minimum of how much in each pocket? Hello?
Yes, sir. Yes, sir. I'm audible.
Hello?
Yes, sir. Hello, sir.
How much should you have in a minimum in each deep pocket?
Yes.
Centimeters.
Yeah. Can you hear me? Sorry.
Yes, sir. Yes, sir.
Yes.
Yeah.
Any
okay.
other?
So you must have a minimum of 2 centimeters in each pocket.
Okay.
You understand?
Yes, sir.
So 2 centimeters in each pocket, which means you will have 2. You divide the ureter into 4 segments. One midline and one horizontal line, dividing it into 4 pockets. Each segment should contain at least 1 pocket containing 2 centimeters. You follow?
Yes, sir.
So that is the basis of 8 centimeters being a normal or fairly adequate lichen. So 5 centimeters means it's very, very poor. You understand?
Yes, sir.
5 centimeters means very, very poor. Now, oftentimes in a PUV, we are all looking at this keyhole sign, but we are forgetting something else very important, which you have to ask the ultrasonologist, which otherwise they may not look at. I said looking at it in real time. What is it that the ultrasonologist should do, which often they don't do?
Dynamic, Sukumar. Anything which is dynamic.
Dynamic.
Vesicular ureteric reflex. So hydronephrosis.
Yeah, vesicular. We spoke about it. Intermittent dilatation of the ureter. What else is the baby doing in utero in the 3rd trimester? The baby does something.
Something dynamics, bladder.
Bladder
something.
cyclings.
Bladder cycling.
Right,
So
right.
you have to. That means, in other words, you have to watch whether the bladder cycles. It takes approximately 15 minutes to watch whether the bladder cycles. So, in other words, when you're looking at hydronephrosis, you're looking at every one of these points. Now, let us say now we have an idea. In the 3rd trimester, this child has an anterior posterior diameter of the pelvis of 10 millimeters, which according to the UTD classification is UTD A1. Correct?
Yes, sir.
So on a UTD A1, what will be the postnatal follow-up as far as this child is concerned?
Immediately after delivery, within 3 to 4 days, we have to go for a postnatal ultrasound, sir.
Okay. Now this is where I think it is important. You never do anything immediately after delivery.
Yes, sir.
Why?
Sir, there is perinatal transition where there is physiological oliguria because of the dehydration of the baby, sir.
Very good. So the baby is losing lot of extracellular water within the first two days. So don't be in a hurry to go in for something within the first 2 days. After 2 days, usually we do it about a week after birth. In a unilateral hydronephrosis, we do a scan. Okay. And we take it further. We'll deal with it a little later. Okay. Now you can continue with your presentation.
So, general examination, child is active, moderately built, moderately nourished, no pallor, no icterus, no cyanosis, no clubbing, no pedal edema, no generalized lymphadenopathy. Pulse rate is 110 per minute. Blood pressure is 80 by 50 mm of Hg, recorded in right arm in supine position. Respiratory rate is 25 per minute. Temperature is normal. Hello, sir. Weight is 4.5 kgs. Mid-arm circumference 11 centimeters. Head circumference is 40 centimeters. Head to examination is normal, sir.
Okay. So I don't know. See, I'm not a great. I examine only for the fellowship, which means when they come already they are pretty ready for all this. But when you go back on one slide, go back on one slide. I think all this can be left out. Child active, moderately built, moderately nourished. And I personally feel that carries no meaning. I personally feel it doesn't carry any meaning. I wouldn't be too worried about pulse rate and blood pressure also, though it is important for you to talk about it, at least to show that you're asking for it, or ask for the BP. You can ask for the BP cuff, because what will happen is, suppose you have, let us say you have a pediatrician in the audience, in your examinership. Then they will ask you, is this the right size of cuff and all, and it's sort of, a situation where you don't really want to be. So I'm just sort of, this is just a personal.
Okay.
It's just a personal step. Okay.
Others kindly unmute.
Yeah. So, I mean, this is just a personal observation, but you can go ahead. No problem. Yeah. So, in all this, go ahead. Abdominal examination. Tell me, sir.
Abdominal examination or inspection. Abdominal normal in shape. Umbilicus is inverted, transverse, and central. No visible dilated veins, no visible pulsations, no scars or sinuses. Left flank is appearing more convex. The left renal angle fullness is present. Hernial orifices are free. External genitalia appears normal.
Okay. All right. Go ahead. See, I really don't. I think we are past the situation where we should really go too much into clinical. I know we can go on for hours on clinical examination, but I think it makes very little difference.
Hello, sir.
Go ahead.
Yes, sir. On palpation, abdomen is soft. There is no local rise of temperature. There is no tenderness. there is a lump which is palpable in the left lumbar region of size 6 into 4 centimeters, and it is vertically oval in shape, soft in consistency, slightly moving with respiration, with smooth surface, with well-defined regular borders. The swelling is bimanually palpable, and the ballotability is present. And we are able to insinuate the fingers between the left corsal margin and the lump, and there is no palpable bladder.
Hello.
Hello, sir.
Dr. Sripathi, sir.
Sorry, sir. I was suddenly the connection went off. My apologies, sir. Now I'm all right. Yeah. So my own feeling is whatever you have said, I fully agree. I wouldn't be too bothered about fullness of the lumbar region and the renal angle and all. First of all, examining a baby of this age and size itself is particularly difficult. So I'm not really worried. If you can feel a palpable lump, that's good enough. That's good enough. Go ahead. Tell me.
Percussion, there is a resonant note over the lump. The liver dullness starts in 5th intercostal space in metacarpal line. Liver span is 7 centimeter. Renal angle dullness is present. On auscultation, bowel sounds are heard. The rectal examination is normal. External genitalia appear normal. Examination of the other system, respiratory system, central nervous system and spine, and cardiovascular system are normal.
I would not do a rectal examination, sir.
Okay.
Honestly, I don't know. I think, as long as you tell me that you can palpate a kidney on the left side, it's bimanually palpable. That's good enough for me. Okay. I wouldn't be too worried about the rest. That's fine. Go ahead, sir.
So to summarize, this is a 3 months old male child with antenatally detected hydronephrosis, which is on postnatal follow-up, otherwise asymptomatic with bimanual palpable soft lump in the left lumbar region. It's probably a left hydronephrosis secondary to pelvic-ureteric junction obstruction.
Left renal swelling. First.
Okay. So it's a hydronephrosis. All right, fine. So it is a left renal swelling, possibly a hydronephrosis.
Yes, sir.
Okay. Now, my only question is, there's something a little abnormal here. In the sense, you have told me it's a UTD A1.
Yes, sir.
Okay. Now, in the UTD A1, I wouldn't actually expect a palpable kidney swelling at 3 months.
Yes, sir.
Isn't it? Palpable. Is there an ultrasound before this? At 1 week after birth or 1 month after birth?
Yes. Yeah. Sure.
Okay.
So this was the investigations done, sir. Ultrasound KUB. First ultrasound was done at 3 days of life, sir.
Very good.
The size of the kidney is 5.4 into points compared to the left side is right side is normal. The echo texture, corticomedullary differential, and the cortex is normal. The pelvic axial system is moderately dilated left side, and the anterior posterior diameter is 16 mm, sir. Okay. When the scan was done at 3 days of life.
Okay. All right.
And the right kidney, bilateral ureter and bladder were normal, sir. And the scan was repeated. Yes, sir.
Yeah. We all talk about anterior posterior diameter constantly, isn't it?
Yes, sir.
Now, when you say anterior posterior diameter, what exactly are you talking about?
So, we are measuring the size of the kidney at the transverse axial plane, sir.
Okay. You're measuring, it's a transverse section of the kidney. Okay.
At what level?
Renal hilum, sir.
Very good. Renal hilum. Which means it's a transverse section at the renal hilum level. Fine. And then where is this anterior posterior diameter then done? Where is the anterior posterior diameter done?
Done, sir.
Where exactly? You have a transverse section of the kidney which shows a dilated pelvis. Then where are you measuring the anterior posterior diameter then?
At the level of renal hilum, sir.
At the level of the renal hilum. At the level of the renal hilum. So, because we are virtual, we are not able to talk about it. But if somebody asks you to draw a picture, let's say the examiner says, can you draw a picture of a transverse section of the kidney and the AP diameter of the recording, you will be able to do it, won't you?
Yes, sir.
Okay, very important. All right. So there are two ways in which this can be interpreted. A lot of ultrasonologists measure it at the widest diameter, AP diameter. Okay. Sometimes this widest diameter may be within the renal substance. But a lot of people measure it at the renal hilum or where the sinus starts and then give you an AP diameter measurement. Okay?
Okay.
So this is quite important for you to see. Now, you have shown me a picture here. Is this a transverse section or is this something else?
It's a longitudinal.
It's a longitudinal section. Now, is it merely enough to look at a transverse section or is it important to look at a longitudinal section? Are you happy merely looking at a transverse section in AP diameter or do you want to look at the longitudinal section?
To see the calcium dilatation, the parenchymal thickness.
Very nice. So, in other words, when you talk about your SFU grading,
Yes,
are you looking at the transverse section or are you looking at the longitudinal section?
SFU grading, we are looking at the longitudinal sections.
Excellent. So you're always looking at the longitudinal section when you talk of the SFU grading, which means though we are looking at the AP diameter of the pelvis in the transverse section, on which we are basing a lot of things that we are trying to do, it's the longitudinal section that we use for our SFU grading. Okay? All right. Now, here is your 5.4 centimeters. So what would have been the size of the other kidney on the other side? Normal side?
It's also the same, nearly same. Sir.
Fantastic. Okay. Okay. Now, straight away when I see this, there's something abnormal here. This is the way that a UTD A1 will behave. 16 millimeters, 5.4, 2.6 centimeters. This seems okay. Why did this suddenly become 8.7 into 3.3 at 45 days of age?
There is a sudden increase in the size. But
exactly. How do you explain that? Can you give me some sort of an idea as to why do you think this would have happened?
Because of the increase in GFR, which happens at the 1 month of age, there is doubling of the GFR. Sir.
Very good, sir. Very good. Very good. And at approximately when is the GFR almost reaching adult levels?
2 years, sir. 2 years of age, sir.
2 years. So there is a progressive increase, and this increase in the GFR is because of actual filtration or because of something else?
Renal maturity.
Excellent. When you talk of renal maturity, what exactly are you talking about? When you talk of renal maturity in a small baby, you're actually talking about recruitment of more and more glomeruli. You follow? Actually, all the glomeruli don't work at all initially. More and more glomeruli are recruited as time goes on. And how is this important for us? How is this important for us? Why exactly are we talking about this? We'll come to it a little later.
Because actually, early intervention.
Yeah, not really. We'll come to it a little later. Okay. So at 3 days of life, in APD is 16 millimeters, it becomes 21, and the kidney has really become increased in size. Also, in this particular diagram that you have made, you haven't mentioned parenchymal thickness. It's something that I'm interested in. I want to see how much the kidney has been stretched.
Actually, in the scan, they said cortical thickness is normal, sir. But they didn't mention about the parenchymal.
Thickness
is normal, sir.
Fine. Very good, sir. Okay. Go ahead, sir. Go ahead.
Sir, the scan was repeated at 45 days of life. There is increase in the size.
But you saw the baby at 30 days of age, correct?
Yes, sir. After 45 days, sir.
After 45 days, the kidney was palpable.
Yes, sir.
So, for a kidney to be palpable, what size of renal pelvis minimum do you expect? Just for the kidney to be palpable.
Renal pelvis.
What renal pelvic size do you expect just for the kidney to be palpable?
4 to 5 centimeters.
Yeah, so it is surprising, isn't it? At 45 days of life, when you have an APD of 2.1, but your kidney is palpable, what exactly does that show you? What I'm trying to show you is I want you to think as you're seeing all this. There is a lot of information to be gained about all this. All right? I want your thinking process to be there, not merely go on values and try and decide whether to do surgery or not.
Apart from the pelvis, there is also calcium dilatation, sir.
Exactly. So obviously the intrarenal dilatation is huge, isn't it?
Yes,
for the kidney to become palpable.
Yes.
Okay. So for the kidneys becoming palpable at 45 days of age, in spite of the APD being 2.1 centimeters, there is something wrong. If you're a kidney of 4 centimeters, as you rightly said, an APD diameter of the pelvis is kidney that's palpable. Okay.
Yes, sir.
All right. Go ahead. Next.
Next, after this, we have done a renogram, sir.
Very good, sir.
Yes, here the tracer used was technetium 99M ethylene dicysteine, sir.
Do you have a picture of the?
Yes.
Do you have a picture of the? Show me the DTP. Okay. Any other shots? Excellent. So we'll just concentrate on this.
This one.
We'll just concentrate first on this.
This
What exactly are we trying to see as far as this is concerned? Tell me.
Sir, actually, there are 3 phases in a whenever ureter scan, sir. One is the uptake phase, next
Okay.
is the cortical transit phase, and third phase is the excretory phase, sir.
Very good, sir.
So immediately after giving a tracer, yes,
Yes, sir. Go ahead.
initially after giving a tracer, there is sudden increase in the perfusion, renal perfusion, sir.
Do you have the perfusion phase with you?
Only vascular
Yeah.
flow is, yes, sir.
Okay. You have the
That's-
perfusion phase, okay, which is on your right hand side, measured 1,
Right,
2,
enlarge.
3.
Enlarge.
Okay.
Sukumar,
So-
enlarge.
So that is your perfusion phase.
Yes,
All right. Okay. That is a perfusion phase. Fine.
Yes, sir.
Very good, sir. Now
Yes.
this is what phase is this?
So this is the cortical transit phase, sir.
Cortical transit phase. Okay. Okay.
Or the
Cortical transit
parenchymal
phase.
approach.
Very good, sir. You're talking about cortical transit phase. Now each of these frames is how many minutes per frame?
So it is 1 minute per frame, sir.
1
Done
minute
for
per
total,
frame.
actually it is up to 18. Actually, we will take up to 20 minutes, sir.
Okay. When you say EC scan, what exactly are you talking about?
It is ethylene dicysteine scan, sir,
Very good.
which is a
Ethylene
tubular,
dicysteine.
which
Yes,
is a
sir.
tubular secretory agent, sir,
Okay.
which is used in renogram.
Okay. How does it differ from DTPA?
So DTPA is a glomerular filtration agent, sir,
Very good, sir.
where we can only measure the only the
Measure.
GFR, sir. So
Okay.
excretion and where in case of AC scan, we can measure both the functional and excretory parts, sir, because
What
the
is the-
uptake
yeah, sorry.
renal extraction is more in case of this AC scan, sir.
Can you see cortex?
Yes, sir.
Can you see cortex in DTP?
Oh,
No, sir.
Cortical lesions.
No, sir. It is a glomerular agent, sir.
The glomerular agent. Now, what is this EC that I see? This EC is something that came recently,
Yes, sir.
isn't it?
Yes,
Now,
sir.
what is this EC equivalent to? Outside the country, what are they using?
MAG3 scan, sir. Mercaptostyle triglycine, sir.
Okay. What exactly does MAG3 do?
Sir, it is it is extracted by the kidney, sir. Afterwards, it is secreted by the tubular agent. It has a high plasma protein binding capacity, so it gives us both functional information and also the excretory information, sir.
So, when you compare DTPA and MAG3, which one has got more plasma binding?
So it has like MAG3, sir, which has got more plasma protein binding capacity.
Very good.
DTPA
More
doesn't have any
protein
plasma protein binding, sir.
does not have any plasma protein
Yes, sir.
binding. Therefore, how does MAG3 help you in determining the function of the kidney?
The uptake.
Yeah, perfectly all right. So, your cortical transit, your cortical uptake is much better as far as MAG3 is concerned.
Yes.
So, it gives you a better index of the renal function.
Yes, sir.
As opposed to DTPA, which is purely a glomerular filtration agent, which gives you just a rough approximation of GFR, but nothing more than that.
Yes.
Okay. Unfortunately, since we don't have MAG3, we've got EC, which approximates MAG3 in its function rather than DTPA.
Yes, sir.
Now, tell me about this. Tell me how you will interpret this.
Sir, actually it is a 1 minute frame, sir, done for totally 20 minutes. There is actually initially there is some differential uptake of in the both kidneys, sir. Actually, it is done from the posterior. So the left is having some reduced uptake of the tracer initially compared to the right side, sir. And then we can see, hello, sir.
Yes, sir. I'm
Yeah,
here.
sir.
I'm listening to you.
Sir,
Yeah.
we are able to see the bladder from the third frame, sir, which
Very
is
good, sir.
okay, which tells about the hydration of the patient. Then there is gradual accumulation of the tracer in the left kidney, sir, and then excretion of the tracer in the right kidney, sir.
Very good. Now,
And
why are we looking at this at all? What exactly are we trying to see when we look at this?
So, whether there is retention of the contrast to see any obstruction.
Okay. You told me that this was the parenchymal transit phase,
Yes, sir.
isn't it?
Yes, sir.
Now, in a parenchymal transit phase, I'm not looking at retention of contrast.
Okay.
I am
Excretory
trying
phase.
to see how much time it takes for the isotope to go through the renal cortex.
Yes, sir.
From the
Cortical
time,
term.
yeah, just
Yes.
the cortical transit, from the time it goes through the cortex to the calyces. All right.
Yes, sir.
Now, based on that, can you tell me what you have inferred on this?
Sir, at around 3 minutes, there is we can see the bladder, sir. So that may be the
Okay.
transit time.
So, okay. Now, I just want you, this is something that I'm going to teach you.
Okay, sir.
You look at this, you look at the kidney here, all right?
Yes,
You
sir.
look at the darkness there, there is a blackness inside and a redness outside. You can see the background
Yes,
of the
sir.
heart there, all right?
Yes, sir.
And then the heart just goes away after the third frame, all right?
Yes, sir.
So there is a blackness here. For this kidney to get that amount of blackness, it takes this frame.
Okay, sir.
Okay, you agree?
Yes,
All right. So when you see initially, you can see just an appearance of isotope in the cortex.
Yes, sir.
All right.
Yes, sir.
This was what used to be called the nephrogram phase in the IVU.
Okay, sir.
And then you can see a central area where there is no isotope at all. That represents
Dilated pelvis.
dilated pelvis, dilated
calcium system.
calyces, all that.
Yes,
Okay. All right. So it hasn't reached the pelvis or it hasn't reached the calyces, but it's there in the cortex.
Yes, sir.
It seems to be a little more, it's coming into that. But if you compare, within 1 minute, it has come into the pelvis and calyces here.
Yes, sir.
But for that to happen here, it has taken 1, 2, 3 minutes.
Brief.
So what is this 3 minutes? What do you call that?
The cortical transit time, sir.
Exactly.
Yeah.
So this is what is called
Yes.
intrarenal transit.
Okay, sir.
Okay. So
Okay.
1 to 3 minutes is normal.
Normal, sir.
Anything above 3 minutes is abnormal.
Yes, sir.
So now, don't worry about the bladder. I know you've been talking to me about the bladder and I have been studiously ignoring you. Don't worry about the bladder.
Okay, sir.
The bladder the urine actually in the bladder is being contributed by this kidney. Can you see how the size of the kidney comes down between this frame and this frame? Between these two frames itself, the size of the kidney has come down. What is very important when you look at these pictures is to tell me that there is a difference in size between the two kidneys. The left kidney is bigger than the right kidney.
Yes, sir.
So when I'm looking at the cortical transit phase, there are 2 or 3 things that I'm looking at. One, I'm seeing how much time it takes for the intrarenal transit to happen.
Okay, sir.
I'm trying to see if there is a size discrepancy between the two kidneys.
Okay.
I'm just seeing whether the other kidney is normal.
Yes.
And you can see that the other kidney has actually disappeared by here, but this is only now starting to fill up the pelvis. You spoke about the pelvis, but the pelvis is not seen till here.
Yes, sir.
Very faintly it is coming up here, which means that's almost 9 minutes.
9 minutes.
Okay, and you can see the pelvis very well here at the 18th minute.
Yes, sir.
Now, this has been written as LASIX F0. What does that mean?
It's the timing of the diuretic injection which is given, sir. That is 0 means simultaneously with the tracer we'll use it.
Along with the tracer.
Tracer.
Now, what is the advantage of doing that?
So single intravenous, we can give
Excellent,
injection at the
excellent.
single shot, sir.
Very good. This is what lot of nuclear medicine departments do because they can't be bothered with giving injection. But if you are to have an ideal situation, when exactly will you give LASIX?
F plus 20, sir.
Yes, at least F
20
plus
minutes.
15. At least
Okay.
F plus 15. Can you see? At 15 minutes, can you see how the pelvis is? At 18 minutes, how you can see how the pelvis is. Therefore, when the pelvis is full, if you give LASIX and thereafter you measure the obstruction, you measure the drainage, then that is a good renogram.
Okay, sir.
Instead, for convenience, we are doing this.
Yes, sir.
You follow? What
Yes,
is
sir.
the most important requirement when you do a LASIX F0? What is the most important requirement?
Hydration of the patient.
Excellent. So the hydration of the patient is very important. If the patient is not well hydrated, you will find a false positive retention of the isotope, which will give you an appearance as if it is obstructed when actually it is not. You follow?
Yes, sir.
Okay. Now, continuing along the same line of thing, suppose you have a study, highly equivocal, you're not very happy, and you tell the nuclear medicine fellow, can you repeat the study? What do you think the nuclear medicine fellow will tell you? You can do something called an F minus 15 study.
Yes, F minus 15.
Okay, F minus 15 study is a good study because you give the Lasix first. Then when the kidney is at its fullness, it takes 15 minutes for the Lasix to act. That time you give your isotope. All right?
Yes.
So if you have an equivocal study, then F minus 15 is what we should be doing. So this is the transit phase. We looked at the perfusion phase, we are looking at the transit phase. Next. Show me the next picture.
Graph here.
Okay. All right.
Yes.
Okay. Okay. So this is, yeah, go ahead, sir. Go ahead, sir.
Sir, it is a Renogram curve where in the left kidney there is a uprising curve, sir,
Okay.
which shows that there is no excretion of the tracer.
Very good. Very good. Now, we normally don't talk about what do you call that? We don't talk about a rising curve. Okay,
Yes,
fine. There is something that they have written here. I'll just take you only through one thing. It's called peak to half peak. What are they talking about?
Sir, actually,
On the normal curve, tell me the peak to half peak.
sir, it is a T half. Peak to half peak is T half, sir, where it is a time required for the half of the tracer to get excreted, sir,
Yes,
to
sir.
get cleared, sir.
Okay, from where?
From
which
T max,
point
sir.
in time?
It's from T max, from the peak, sir.
Can you
T-max.
show me the peak on the normal side?
Sir,
Show me the peak on the normal side. That
yes,
is
sir.
the peak.
Yes,
What
sir.
is the count at that particular level?
It's around
3.
count, sir. Count is 300, sir. Minutes is
300.
less than, yes.
When does it reach 150? Show me on the curve. When does it reach 150?
So 6 to 7 minutes, sir. I guess,
Okay.
12 minutes.
Okay, it reaches 12 minutes.
Yes.
All right. So in other words, this peak is at 2 minutes. This is at 12 minutes. So 12 minus 2 gives you a T half of 10.
10, sir.
Okay. Is it T half of 10 okay?
Sir, less than 10 is normal, sir.
Perfect. So in other words, they don't have to give you all this. You
Yes,
can look at the curve and tell you.
Okay.
Now, is it even possible to measure T half here?
No, sir.
Why not? Why not?
We are not able to see the peak, sir.
We're not able to see the peak. In other words, we do not know what the Tmax of this kidney
Yes,
is.
sir.
Since we do not know what the Tmax of the kidney is, it's impossible to calculate the T half.
Yeah.
So the peak to T half, we don't know.
Yes,
All right?
Yes, sir.
Okay. Now forget about the other things. They're very confusing. So in terms of uptake here that they have written, uptake percentage. What is the uptake percentage that they have spoken about?
The left is 56.61, sir. Right is 43.39, sir.
43.39. Let us say we have a drainage curve, which the peak is here, and then it keeps going, giving you a T half of 22. What does that mean?
T half greater than 20 is like obstructive pattern, sir.
Obstructive pattern. T half of 15.
Indeterminate, sir, between 10 and 15.
So these are just values. Essentially, they are values. So what I want you to know is, if somebody talks about this, you say, I'm not going to rely on the uptake drainage curves at all.
Okay,
Primarily because this has been done in the lying down position. Were I to repeat the same thing in the standing up position, I might find a completely different drainage
gravity
curve.
driver.
All right?
Yes.
And it's also dependent on a lot of other issues. And that brings us to the question, what is a well-tempered renogram?
So a well-tempered renogram is we have to give the diuretic when there is complete accumulation of the tracer in the pelvis.
Okay. You spoke about something earlier. You told me the child was well hydrated.
Yes, sir.
Is that a part of the well-tempered renogram?
Yes, sir. Actually, they have well-tempered is like a format guideline so that they have to follow universally all the things, protocols.
Excellent. So, okay, okay. What else is there in the well-tempered renal?
Sir, first is
Which
the
has a
hydration
relevance
of
to this? Which
bladder
has a
drainage.
relevance to this? Bladder drainage. Okay, bladder drainage. So, a full bladder, will it impede or will it help for pelvic drainage?
Just before the scan, we have to empty the bladder, sir.
Just before the scan, we have to empty? Do we do that? We don't do it at all. Because the child is not under our control in the nuclear medicine department. Okay, we can't tell them, please make sure bladder is empty as you do the study. We can't tell them that. Okay, so show me the remaining pictures that you have. Okay, all right. So these two pictures, let us talk about these two pictures. Now, what exactly does information does these two pictures give?
After the micturition,
Yes, sir.
sir, images taken after the micturition, sir.
Sir, okay. Yeah.
On
Can
the
you tell
delayed
me, just looking at these pictures, can you give me an idea what is happening after micturition?
There's still retention of the tracer in the left kidney, sir.
Okay.
And
Delayed film. Delayed
yes,
film.
there's still retention of the tracer in the left kidney, sir, with
Okay.
minimal activity in the bladder, sir. Right, almost all it is activity is nil, sir.
Activity is nil. Now, if you ask me what my interpretation of this is,
Yes, sir.
I'm a little worried when I look at this because the kidney size has come down. Here there is a bladder that is still seen.
Yes, sir.
I'm able to see the pelvis. I'm able to see a lot of hot isotope inside the kidney. Between this and this, I can see a renal size difference. The pelvis has come down in size and the bladder is empty. So my worry is there a reflux also along with this? Okay.
Okay.
All right. So
Yes, sir.
what I'm trying to say is there is this much of information that you can get from an EC scan when you're
Okay,
looking
sir.
at all this.
Okay,
All
sir.
right. Now,
Yes.
let us say the delayed film was exactly like your post-dynamic film.
Yes, sir.
I will have no hesitation in taking up this child for surgery.
Okay, sir.
All right.
Yes.
The fact that I'm able to see this kidney decompressing a little, the fact that the pelvis is draining with an empty bladder, I'm worried whether there is reflux as far as this child is concerned. Let us see how things go. Yeah, go ahead.
So we didn't do MCU in this child, sir.
You didn't do MCU. Therefore, now tell me,
Yes, sir.
what are the indications for doing MCU in a child with a PUJ obstruction?
Sir, when the APD is greater than 10 mm,
Okay,
with SFU grading 3 or 4, and with when if the child is having ureteric dilatation on ultrasound, and if the child has episode of UTI, urinary tract infection, sir. These are the indications for MCU in a hydronephrosis.
in a hydronephrosis, yeah.
Yes, sir.
In solitary kidney,
Yes, sir.
ectopic kidney,
Yes.
all those are indications or not?
I don't know. Solitary.
See, I will agree with whatever you said, except
Yes, sir.
your statement about the size of the renal pelvis. The size of the renal pelvis and the SFU grading has no relationship to you doing an MCU.
Okay.
What you said about UTI is very important. Let us say you're able to see intermittent dilatation of the ureter on the ultrasound. The other important point is when they do an ultrasound, this person who does the ultrasound says that the renal pelvis is 3 centimeters on a full bladder.
Okay.
And after the bladder is drained, the pelvis is 1.8 or 2 centimeters. That is a child on whom I'll do an MCU because obviously there might be some reflux that is contributing to this. You understand?
Yes, sir.
Okay. So the definite indication is the presence of ureter, even intermittently seen, the presence of urinary tract infection. What percentage of unilateral UPJs have reflux?
10%, sir.
10%. Approximately 10% have BUR. Okay, fine. Very good, sir. Very good. Now tell me this, sir. Show me this. Discuss this.
Sir, EC scan report, sir. They said
Very
that, that the tracer used is technetium 19 ethylene dicysteine. Diuretic protocol is F0. The finding, sir, vascular flow is normal in both right and left kidney. The tracer extraction is moderately decreased in the left kidney. Coming to the morphology, the kidney is grossly enlarged with thinner cortex. And the split function is 34% in the left kidney and 66% in the right kidney. The collecting system is grossly dilated. And the drainage pattern, there is accumulation shown above the pelvic junction.
Okay.
And the Renogram curve, time to peak not reached.
Okay.
And the delayed scan on the right side, time to peak is 2 minutes and T-off is 5 minutes, according to the reports. And the delayed scan shows.
Yeah, sorry.
Delayed scan shows significant retention above the left pelvic junction.
Okay. Can you go back to your pictures again? Your EC scan pictures. Okay, sir. Now the previous one. Here they have written uptake is 56 and right is 43.
Yes, sir.
Where did they come with this opinion of 34%? On your report, you said 34%, which
Yes.
means was there another DTPA scan or was there only one?
No, it is only one scan, sir.
One scan. Okay. So this makes me a little confused. 56 and 43, and you have said 34. Okay. All right. Do you think it makes a difference?
Yes, sir. Function is actually left is over uptake is more.
Yeah. Yeah. Okay. But here you have said 56, but in actually you have said 34. Am I right?
Yes, 34, sir.
34. Okay. All right. So this makes it completely different. Now, tell me, if it is 34, what is going to be your opinion or what is going to be your decision? If it is 56, what is going to be your decision?
If the split function is less than 35 to 40%, we have to go for surgery, sir. And if it is 55%, actually it is a overestimated or supranormal function, sir.
Okay. All right. What is the reason for a supranormal estimation of function?
Because of the dilated system. Stasis. Dilated system, there is stasis.
So there is obviously more isotope coming, yes, and there is a term for that. It's called signal to noise. It's called signal to noise ratio, which means there is more signal coming up as opposed to the background noise. Therefore, there is more. It shows as more function. In actual fact, there is not that much function. Okay, so we still have this doubt as to whether if it is 34. Suppose it is 56. Are we allowed to just watch this kidney without really getting into surgery?
No, sir.
Okay.
We have to go for surgery, sir.
Why would you say that? Why would you say that?
Because
why would you say that?
It is a curve is uprising curve and the T-off is greater than 20 minutes.
Go back to the next picture. Okay. So, as I said, the drainage curve over time doesn't really matter too much, especially in an F0 study or whatever it is.
Okay.
Now, it is important to look at the uptake percentage. Go to the next picture. So, let us assume it is 56%. There is a delayed intrarenal transit. Next picture. And you find that there is a decrease in the post-dynamic phase with some element of drainage. There is absolutely nothing wrong with waiting on this chart. Okay. Now, don't be carried away by the obstructive curve because there are definite studies which have shown that if you wait for a period of time, the drainage can spontaneously become normal. Okay.
Okay.
All right. Now, on the contrary, if you were to tell me that it is just 34%, I completely agree with you saying that I won't wait anymore.
Yes.
But even then, in this case, based on this alone, I will do one study before I proceed with pyeloplasty. What study will that be?
MCUG.
Okay, MCUG. Let us say, your boss, Narendra says, no MCUG, I don't like MCUG, unilateral UPJ. You are going to create an infection. Anything else that you would like to do?
What is your policy, sir? Routinely, for a unilateral hydronephrosis, we are not doing.
No, we are not doing an MCUG.
Unless there is.
Yeah.
Unless there is a UT.
Sir, my policy is I don't do an MCU at all, sir. unless there is a urinary tract infection.
Okay.
Absolutely,
That's what
without
we
a
are
doubt.
following.
Absolutely, without a doubt. But in this particular case, I'm a little worried about this. And given the fact that there is this difference in percentage function of 56 and 34, this is the sort of case where I would, if I'm not going to do an MCU, then I'll do a retrograde study before I proceed with the pyeloplasty.
Retrograde pyelography.
Okay, I'll do a retrograde study just for me to know what is happening. What do you think I'll find on the retrograde? What do you think is in my mind? Can you go back to your earlier slides? Go back to your earlier slides. Go back. Yeah, this. Can you see next one? Sorry. Next one. See, this is what is absolutely surprising, isn't it? From 3 days to 45 days of life. Because when you presented in the history and you said there is no sudden increase in size of the kidney and then a lot of urine passing and the pain going down, I thought you were actually talking about a crossing vessel. It's only a crossing vessel which will cause this.
Okay.
You follow?
Yes,
so
sir.
that's a distinct possibility. It's also a crossing vessel which will cause this wild variation in function. Okay. It's also a crossing vessel which will show that decrease in size with the bladder drainage. Okay. So putting all this together, this is what I was having in mind when I said that I'll do a retrograde study.
Okay.
So what I want all of you who are listening to this is, when you follow a systematic approach right from the beginning and keep going, a lot of facts will come to your mind. All right. So it will decide what should be your further action. Do not have ideas like, if it is 2 centimeters, I'll go for surgery. If it is 3 centimeters, I'll go for surgery. No, that's not the right way to go about it. Have a proper algorithm in your mind. Look at all investigations carefully and then proceed. Okay, next. Sorry, you go on with your presentation.
Sir, you have to go for surgery in this child, sir. So this is the last slides.
Okay, so you went in for surgery. Okay. So you went in for surgery on this child. Fine, sir. Very good, sir. And what is the weight of the baby, sir?
4.5 kg, sir.
Okay, sir. So what sort of surgery are you going to do on this child?
Anderson-Hines dismembered pyeloplasty, sir.
Sir, when you talk of dismembered pyeloplasty, what are you talking about?
So we are excising the pelvic junction, sir.
Very good, sir. Yeah, this, I'm asking you, what are the principles of an Anderson-Hines pyeloplasty?
Principles, sir. We have to get a funnel shaped. You are asking the steps of surgery, sir, or principle?
Just tell me the principles, basically.
Sir,
now, just think of me as an MBBS student who's coming into your theater. You are the consultant who's operating. And I'm saying, sir, I want to know what this Anderson-Hines pyeloplasty is all about.
Sir, here we'll identify the diseased pelvic junction, and we will excise the pelvic junction, or if necessary, if there is excess redundant pelvis, we can excise the redundant pelvis and do a pelvic anastomosis.
Okay. What is the aim? Finally,
so
how it should look?
We have to get a funnel-shaped, watertight, tension-free anastomosis, dependent anastomosis.
Most important is
dependent anastomosis.
Excellent. So it has to be a dependent anastomosis. Okay. All right. Now, what are the approaches to the kidney?
Sir, we have 3 and open we have got 3 approaches, sir. One is anterior flank approach and posterior lumbotomy approach, sir. In laparoscopy, we have got transperitoneal and retroperitoneoscopic approach, sir.
Very good, sir. You describe to me how you will do an open anterior approach, right, sir. From positioning the child. Tell me how you will proceed.
Sir, in a supine position with slightly elevated on the operating side, we'll place a pillow underneath the flank, sir. Okay. And then we'll give a incision on the anterior side, starting from the tip of the 12th rib, around 4 to 5 centimeters incision. Then we have to incise the fascia. Then we have to do muscle splitting. We have to split the muscles, sir. We have to incise the external oblique along the line of fibers, and we have to split the internal oblique muscle and the transverse abdominis muscle. Then we have to push the peritoneum medially. Then we will see the gyrotose fascia, which has to be incised longitudinally, After incising the gyrotous fascia, we have to identify the pelvis and identify the pelvic-ureteric junction. Put 3 stays, sir. 3 stays, one above and below the on the two on the pelvis, one on the medial side of the ureter, and we have to excise the pelvic-ureteric junction, and we have to start anastomosing from the caudal-most region, sir. That is after giving a spatulation after the lateral, use spatulation on the lateral side of the ureter. So we have to start on the caudal end where the stitch has to come outside the lumen, sir. We will use a 5-0 or 6-0 monofilament absorbable suture material for doing anastomosis.
Okay.
Then,
now, when you are speaking about this, when you are talking about, you spoke about the stay stitches.
Yes, sir.
Why the stay stitches?
Sir, we must not handle the pelvis or the ureter too much, sir, so that there may be a vascular compromise. So whenever we want to handle this, we have to only handle with the stay suture, sir. On the medial stitch for identification, for the giving a spatulation, we have to just do spatulation opposite to that stitch, sir, on the ureter.
Opposite to the stitch. How far do you spatulate? When do you stop spatulate?
Until we see the normal mucosa and there is bleeding from the edges.
Normal mucosa? What normal mucosa?
Folds. Folds.
Mucosal folds.
So when you see mucosal folds going down, that is the point when you stop the spatulation. Okay. Now, you have you kept on saying excising the renal pelvis. What exactly you're talking about is dismembering means separating the pelvis and the ureter.
Yes, sir.
You're separating the two.
Yes,
if at all you excise, you're excising only a small segment.
Yes, sir.
And then you're spatulating the ureter. Now, how do you decide where to anastomose?
It is the most dependent position.
I'm just scrubbing up. I'm a sister who's scrubbing up for the first time. I want to know what this most dependent is. Tell me what the most dependent is. How do you, what relationship do you use when you say the most dependent anastomosis?
The caudal most stitch, sir.
Anything related to the calyces?
Lower calyces.
Exactly. The lowermost calyx. It's in relation to the lowermost calyx. If you look at the lowermost calyx and you imagine that from there the pelvis has to come out, generally, when you speak of dependent anastomosis, you speak of a funnel which starts there, goes all the way down to the PUJ, and your PUJ is placed below the lower pole of the kidney.
Yes, sir.
You follow? This should
Yes,
technically be a dependent anastomosis. But oftentimes, let me tell you, it is very hard to get an anastomosis below the lower pole of the kidney. It's quite hard to do that. All right?
Okay, sir.
Okay. Now, let us give you some sort of situations. You spoke about trimming the pelvis. Do you have to trim the pelvis in every case?
No, sir. No date, sir.
Yeah. So, what are the conditions are there in which you would trim the pelvis?
When there is excessive redundant pelvis.
Is that the only reason, or why are you trimming the pelvis at all? I am saying don't trim the pelvis. Do a dependent anastomosis, it should drain. You are the person who spoke about 34%
yes,
function. Is that poor function or good function?
It's a poor function, so less than 40%.
When you are having a poor function and when you are having a large pelvis, it's not very efficient drainage.
Okay.
All right.
Okay.
So when you trim the pelvis, you are actually increasing the efficiency of emptying of the pelvis.
Okay.
Okay. I'll give you a second situation. You have dismembered, you have separated the pelvis and the ureter along with a small cuff of the pelvis, which you are using to hold because you don't want to handle the ureter too much.
Yes,
then you spatulate, and it comes to the level of L4, L5. Now you are finding that the kidney is up there and your ureteric cut is down below. How are you going to bridge the two?
Sir, when the kidney is at the level of L4 and the ureter is at the level, you can do
No. Kidney is up. Kidney is up at the level of L1, L2.
Yes,
your ureteral cut is at level of L4. There is a 4 centimeter gap. How are you going to bridge it?
Sir, when there is redundant pelvis, we can do a flap thing, sir.
Okay. Describe to me a flap that you use.
Sir,
some named flap,
yes,
unnamed flap, whatever.
Yes, sir. Scadino prints.
Okay.
Vertical flap ureteroplasty, sir. When this is a box-shaped pelvis, we'll give a rectangle incision over the redundant pelvis, and we unfold that, and we will try to anastomosis to the ureter, sir.
Okay. All right. So
One
there
more.
is a very important principle in this. The important principle is you spatulate the ureter
Yes.
before you trim the pelvis. You follow?
Yes, yes, sir.
People get into trouble because they handle the pelvis before they actually handle the ureter. Therefore, you have to decide the distance between the pelvis and the ureter before you handle the pelvis in the first place. Okay, you can use any type of flap that you want. Okay.
Okay.
Let us say I'm not able to do anything at all. There is no way that I can bridge this. What can I do? What are the other options that I do?
Can I go for we go for ureterocalycostomy, sir?
Ureterocalycostomy. What are the conditions that are required for ureterocalycostomy?
It has to be a very much dilated lower calyces with thinned out parenchyma, sir.
Because what is the single most important requirement when you do a ureterocalycostomy?
Dilated lower pelvis with thinned out parenchyma, sir.
Yeah, you have to amputate the lower pole of the kidney.
Yes, sir.
You follow?
Yes,
you have
sir.
to amputate
Amputate.
the lower pole of the kidney. What is the commonest complication of ureterocalycostomy?
Anastomotic leak, sir.
Anastomotic stricture.
Stricture. Okay, sir.
Very easily it strictures. Very easily it strictures. Okay. So
Okay,
what are the conditions when you will actually use a ureterocalycostomy?
Redo surgeries. Redo
Exactly.
surgeries.
When you do a redo surgery, when there is hardly any pelvis, your ureter is way below, it's a huge kidney, very thin parenchyma, you will amputate the lower part of the kidney and anastomose the ureter to the lowermost calyx.
Okay, sir.
All right?
Okay,
Okay.
sir.
Any other option to bridge the gap? Any other option?
Can you
Okay,
bring
please
the
continue.
kidney? Can you bring the kidney down or bladder up by any way?
Can you mobilize the kidney? That's a very, very important point. Can you mobilize the kidney? You can mobilize the kidney.
Okay, sir.
You follow?
Yes, sir.
Within the gyrotous fascia, if you strip away all the fat in the kidney, you can drop the kidney down. All right?
Okay,
You
sir.
might get about a centimeter, centimeter half, and if you're lucky, even 2 centimeters.
Okay,
Right?
sir.
You can bring it down. You can bring the kidney down. Let us say you're bringing the kidney down, still you have a gap, and you're worried, and you can't bridge this gap now. What are you going to do? What are your options? Can you think a little out of the box?
Can we do you separate an appendix?
You can use the appendix on its blood supply. Yes.
You
Okay.
can put it as a conduit.
Now, let us say the appendix is not available. It's the left-hand side. The appendix is not coming this far. It's the left side. What can you do?
Can you
You
lift
can
the
use-
bladder?
What is Sir saying when he says lift the bladder? What is he trying to say?
Sure.
What stitch?
Boss hitch you can take. So I hitch.
Yeah, you can take a psoas hitch. You can bring the bladder up on a psoas hitch. That will get you
sir.
your ureter up a little bit. All right.
Okay, sir. Okay, sir.
Okay. Suppose you had only the small bowel, you can do a Monty. You
Okay,
follow?
sir. Yes.
You can do a Monty to bridge the gap. But most of the time, if you're judicious with using the pelvis, that's the most robust way to bridge the gap
Okay.
and get it. Now, let us say we have a situation where there is a crossing vessel which is causing this problem.
Yes, sir.
Tell me the ways in which you can deal with the crossing vessel.
We must not do anything to the crossing vessel, sir. We have to dismember and anastomose anterior to the crossing vessel, sir.
I am telling you, boss, I believe in the latest technology. I don't want to dismember the pelvis.
Vascular hitch we can take, sir.
Can you describe the vascular hitch to me?
Yes. We
No,
have to
no
mobilize
problem.
anteriorly.
Just mobilize the
towards the
vessels.
pelvis. Mobilize the vessel
Very
towards the
good.
pelvis, sir.
Pelvis and put it in a gutter in the pelvis.
Yes.
All right.
Yes.
Create a gutter in the pelvis and suture the pelvis on top of that, so the vessels no longer come across the PUJ.
Yes, sir.
All right.
Yes, sir.
So this is the reason why you would do, if you do an antegrade study before, and a lot of people do that. What really happens is you have an idea of the length of the ureter. You have an idea where it joins the PUJ. Okay.
Okay,
And then you can decide on a lot of issues which need to be dealt with at that particular time. Let us say Dr. Narendra was talking about a horseshoe kidney before.
yes, sir.
I'm having a PUJ obstruction in a horseshoe kidney.
Okay, sir.
All right, I'm having a PUJ obstruction in a horseshoe kidney. How is it going to be different? I'm telling
high
you,
insertion of the, there will be high insertion of the ureters.
very good.
The
What other
pelvis.
problem is there? As
Isthmus
far
will be
as
there. So,
exactly, exactly. So the isthmus will be there. Will your technique differ because it's a horseshoe kidney?
no, sir, we must not do anything with the isthmus, sir.
Okay. What exactly technique will you use if you have a horseshoe kidney? Will you do the same dismembered pyeloplasty? Will you do something different?
If there is high insertion of ureter over the pelvis, we can do a Foley's YV plasty, sir.
You can do a Foley's YV plastic. Okay, a lot of those techniques, though they are spoken about, hardly anybody does them. But I'm just trying to tell you that you have to remember when you're taking up a child with a horseshoe kidney, you have to look at the local anatomy and then decide what you need to do. Oftentimes, a horseshoe kidney is the sort of situation where you don't dismember the pelvis. You make an incision in the pelvis and ureter and anastomose them in such a way that your anastomosis comes at the level of the isthmus or slightly below that, without actually dismembering the two.
Okay, sir.
It's one of the situations where you have to use it. Okay.
Okay, sir.
Now, you have done the anastomosis. Okay. You have done
Yes,
the
sir.
anastomosis. Will you use a continuous stitch or a running or an interrupted stitch?
Normally, we'll use a continuous stitch, sir.
Use a continuous stitch. Okay. Any part of your anastomosis you want to do interrupted at all? I mean, I'm an old-fashioned fellow. I want to do interrupted. Any part of your anastomosis you'll do interrupted, or it's always continuous right from the beginning? Now, these are all. Let me tell you again for everyone listening. These are all stupid questions. Okay, and they are all designed to irritate you. Okay, you can do whatever you want. You can do continuous. You can do interrupted. We don't care. All right.
Okay,
Sometimes there are some people who put a few interrupted stitches at the bottom, one at the apex, one on either side, and then do continuous on either side. Just doesn't matter at all. Now, after that, what do you do? You have anastomose. Now, what do you do? What else do you do?
We'll put a normally during the anastomosis we can put a double J stent, sir,
Very good.
before closing up the anastomosis.
How old is this baby, sir?
4 months. 3 months, sir. 3 months.
What size of double J stent will you use?
Sir, it is 313, 312, sir.
3 French.
3 French, sir.
Okay. 3 French, 12. Why 12, sir? Why 12? Why 12?
The length is 12 centimeters.
Suppose I tell you, I am the sister in charge of the case. I tell you, sir, we only have 8 centimeters. Are you okay with that?
Because both ends, one end must be in the pelvis and one end must be in the bladder.
This is another way of asking you what is the length of the ureter in a 3-month. You understand, or a 4-month. That's all. I'm just trying to tell you that 8 centimeters is good enough. 10 centimeters is overkill. 12 centimeters is too much. For the very simple reason, when you put a stent, you have to take into account the growth of the child over the next 2 months.
Okay.
You must also take into account stupidity of the parents who might not come for another 6 months.
Okay.
And you don't want the stent to go into the ureter. All right.
Okay, sir.
All right. If you put too big a stent, what is the problem? Length. The stent can migrate outside.
Yes.
You follow?
Yes, sir.
Okay. Now, as you're putting the stent inside, what sort of guide wire will you ask her to get ready for a 3 French, 13 centimeters or 12 centimeters stent?
Guide wires.
Yeah. What size guide wire?
Nowadays.
Your boss is
Point.
telling you, yeah, boss is telling you,
0.05. 0.0.
Okay.
0.018
Okay.
is your guide wire. Okay,
Okay.
0.018 is your guide wire. You're putting the stent inside. How do you know you've reached the bladder?
Urine, when the urine is draining from the tips.
Very good. Urine is draining from the tip. There is no drainage of urine from the tip because of what reason? Why do you think there is no drainage of urine when you put the stent inside? Because you may not have clamped the bladder catheter when you started the operation.
Okay.
You follow?
Yes, sir.
So the first thing that you have to do is, once you put a bladder catheter, you clamp the catheter
Okay, sir.
so that your bladder becomes full. Now, I still am a very particular fellow. I must say, I must know whether the stent is in the bladder or not. What technique can I use to find out whether the stent is really in the bladder? Foolproof technique I want.
X-ray, we can do a fluoroscopy.
Fluoroscopy, very difficult with a small baby lying on the side, edge of the table. Very difficult. You can do fluoroscopy, of course.
Yes, sir.
Of course, but you have to shoot from the side. Anything else I can do? I can put a drop of
any dye
dye.
test.
Dye you can put.
Yes.
What dye? You can put methylene blue.
Methylene.
You can put a drop of methylene blue. All right. And what happens is when you put the stent inside, blue urine comes up, and you know you're there.
Okay.
All right.
Yeah.
Okay. Now let us say we belong to All India Institute of Medical Sciences. Well, I know all those chaps there, so I know they won't be upset. All India Institute of Medical Sciences, and I say I don't believe in DJ stent. What else can I do?
We'll put a sometimes they will not put a stent, so we'll put a perinephric drain and come out.
Can put a perinephric drain and come out. Yeah, fine. But not a great idea, because today I think if you have a leak and a fibrosis, you are in trouble.
Yes.
That's an alternative to this, because I am an old-fashioned examiner, and I'm telling you, I don't want to give this child anesthesia again.
Yes, we can put a stent, anastomotic stent, and take out from the so that next time there is no need to give anesthesia for stent removal.
Okay.
Then, and along with that,
PCN has to be done, sir.
yeah.
Percutaneous nephrostomy has to be placed, sir. So,
so you can put a nephrostent.
Nephrostent.
You can put a nephrostent. You can keep inside. How long do you have to keep a stent inside?
2 weeks, sir.
Okay. All right.
Then we have to do a nephrostogram. We have to do a nephrostogram.
All right.
To check for any check for whether it is draining well or not. If it is draining well, we have to take out the nephrostomy tube, sir.
Nephrostomy tube, and you can take your stent out as well. Yeah. Normally, you put a DJ stent. How long do you keep it?
It's 4 to 6 weeks, sir.
4 to 6 weeks. What instruction do you give them when they go home on the stent?
We have to put it on antibiotic prophylaxis.
Antibiotic prophylaxis. You tell them. Okay.
Yes, sir.
Now, I put the stent inside. All right. Yes, I think I'm fairly sure it's inside. But then I ring up the resident at night and ask, boss, can you tell me whether the stent is inside? Is there some way you will know whether the stent is inside?
Check X-ray.
Any change in the color of the urine?
Hematuria will be there. Hematuria will be there.
That is the first thing that you check.
Sir.
Okay, but the moment you see hematuria, see a lot of this is only common sense.
Okay.
If you see hematuria initially, then you will know that your stent is inside. All right. Yes. So you have stented. Now you have told me an anterior approach. You have told me an anterior approach, tip of the 12th rib. You said 3 centimeters anterior, correct?
Yes, sir.
Okay. Now I'm saying, not very happy. I want to do a flank approach. Describe a flank approach to me.
Sir, it is a muscle cutting incision.
Okay. And child is in what position?
Completely in posterior lumbotomy, it is prone, sir. In the flank,
posterior lumbotomy, it is prone.
Okay. Prone, sir.
Okay.
This is it. Sir asking about flank.
It's lateral position, sir.
Okay, it's a lateral position. Lateral position. Describe how you will put the child in position for me.
So, you have to put in lateral position, and we have to increase the gap between the bony kib and the spine.
Very nice. Okay.
Open up the flank, sir.
By putting up a roll under the lower ribs.
Yes.
Okay, you put up a roll under the lower ribs, then you strap the child.
Yes.
All right. Then you make your incision. Now, where will you make the incision?
2 centimeters below the costal margin, sir.
Okay, 2 centimeters below the costal margin is actually, it's very funny. This is something that I wanted to want to tell you people.
Okay, sir.
There was a demonstration in SGPGI a long time ago,
Yes, sir.
where one of the American surgeons was showing pyeloplasty, and he said the pyeloplasty incision they put depends on how big the pelvis is and where the PUJ is.
Yes, sir.
So it keeps on varying. But
Okay,
I feel a standard approach is quite essential. If you put a flank incision, what you can do is you can take one finger breadth from the tip of the 11th rib and make a transverse incision, cut all the muscles in the flank, and straight away approach the kidney.
Okay.
Now, suppose I tell you, I want an incision which will take me exactly onto the pelvis.
Posterior lumbotomy incision, sir.
Okay?
It is
Describe the lumbotomy to me.
Sir, in between the 12th rib and the spine, we have to give either transverse incision along the Langus line or vertical incision, sir,
Okay?
where we can directly approach the pelvis.
Very good. Very good. You can approach the pelvis. Now, we won't go into the details of the lumbotomy. What are the specific problems with the lumbotomy?
So whenever it is a malrotated kidney, it may be difficult.
Very good. What else?
And we can see the aberrant vessels if there are any, sir.
It is difficult to see aberrant vessels with a lumbotomy.
Yes, sir.
Okay, in a prone position. Like in this particular case. All right. Another problem with a lumbotomy. Another problem with a lumbotomy is a large pelvis.
Okay.
Sometimes you are very limited in dealing with a large pelvis if you have a lumbotomy incision, because a lumbotomy incision cannot be enlarged that much.
Okay.
If you try to enlarge a lumbotomy incision, you'll end up with a very big scar. Are there any other approaches that you know? Can you go along the rib? You can go along the rib.
Okay.
You can go along the 12th rib, all right?
Okay.
And do a subperiosteal excision of the 12th rib.
Okay.
Make an incision in the bed of the 12th rib, in the periosteum, and you'll be bang on the renal pelvis.
Okay.
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 And these are approaches along the 11th rib or along the 12th rib. You can open the renal pelvis and especially take out calculi. They're very good incisions for that.
Okay, sir.
Very good incisions for that. So if you know a flank approach, if you know a lumbotomy approach, if you know this approach along the rib, you're done. Okay. Tell me some minimally invasive methods of doing a pyeloplasty.
Minimal invasive or endopilotomy, sir. Either it may be retrograde or antegrade pylotomy.
Very good.
And there is a laparoscopic pyeloplasty, sir.
Okay, a laparoscopic pyeloplasty. Fine, very good, sir. So the technique of any minimally invasive pyeloplasty can either be retroperitoneal or transperitoneal. A lot of these are only the theoretical discussions. Exactly the technique that you would follow. So I don't think we need to go too much into that.
Okay.
The other question that I wanted to ask you is, what sort of follow-up will you do after you do a pyeloplasty?
Sir, after doing a pyeloplasty, I want to do ultrasound scan at 3 months of age, sir, to see whether there is any resolution of any hydronephrosis or not, and do a renogram 6 months.
This is after removal of the stent or before removal?
Sir, after removal of the stent.
After removal of the stent, you wait for 3 months.
Yes, sir.
And then you do a ultrasound.
Ultrasound, sir.
Okay. Okay, you do an ultrasound. What exactly are you looking in the ultrasound?
Sir, the pyeloplasty, whether there is a decrease in the grading of the hydronephrosis and there is any increase in the temporal axial length of the kidney, sir, and any improvement in the parenchymal thickness, sir.
Improvement in the parenchymal thickness. Okay. All right. Now, but I am telling you, doctor, you have reduced the size of the pelvis, doctor. How do you not expect the SFU decrease to decrease? Why are you asking for ultrasound at 3 months? You have reduced the size of the pelvis. What exactly is this 3-month review that you want? Why do you want it? You have taken out the stent. Why do you want this review at all?
Or not, sir? Whether the anastomosis is draining or not.
So what is the one thing? What is the one thing that you'll ask the ultrasonologist? You'll tell the ultrasonologist, boss, please tell me what is happening as far as this child is concerned. What is the one thing that you will ask? You will ask him about how tense the calyces are. All right. Now you would expect the calyces to be flattened. All right. Not tense at all. The moment the ultrasonologist rings up and tells you, I know it's a post-pyeloplasty situation, but the calyces are tense. They are as tense as they were before you started the operation. And you know you're in trouble. Okay?
Okay, sir.
you're in trouble. All right. Okay. Let us say you have that sort of a situation in this particular child. Now, how are you going to approach it?
Sir, I will do a renogram.
Okay.
Repeat
Renogram shows, I'll give you a hypothetical answer to the renogram. You started off with 34% function.
Yes,
The
sir.
kidney is now 20% in function.
Decrease.
With a climbing curve. Now, what are you going to do? How are you going to manage this? The
When
kidney
there is decremental in the function.
There is decrease in the function of the kidney. The calyces are tense. The kidney is palpable again. What are you going to do?
At least wait for 2 months to do a radiopyloplasty.
Why do you want to wait for 2 months? The father says already 14% is gone, doctor. Why should I wait? Please tell me what to do. It is 3 months since you did your pyeloplasty. Okay. The kidney
is there
weak.
any other methods of draining?
Sir, other methods of drain when there is obstruction. Pylolymphatic, pylovenous.
No. He is asking you a practical question.
Yes,
the
sir.
kidney was 34, now it is 20.
Yes, sir.
All right. The kidney is palpable. The calyces are as tense as they were before. You have done an operation. Now the father is demanding relief. What are you going to do?
ECN, sir.
Oh. ECN, sorry. When you say
Percutaneous
ECN.
nephrostomy.
Okay. You're talking of percutaneous nephrostomy.
Nephrostomy,
perfect. Very good. A percutaneous nephrostomy will buy you time.
Yes, sir.
All right. Percutaneous nephrostomy will relieve the obstruction, buy you time. Will also tell you what else.
Yeah. We can do a nephrostogram to see whether it is draining or not.
Will a nephrostogram alone be enough, or you need to do something else? You need to inject contrast into the ureter also to see what is happening because the nephrostogram will give you an idea of the renal pelvis.
Okay.
But will not give you an idea of the PUJ and will not give you an idea of the ureter. So you might have to inject contrast from below. So this is the sort of situation where you have to decide whether there is an open patent tract. If there is a tract, whether you can put a guide wire and pass a stent across it to help temporize the situation, or what are the possible reasons for failure of a pyeloplasty? That is the question. Yeah, sorry.
Urinary leak, which may cause a fibrosis at the anastomotic site.
Oh, okay. So in other words, you're talking about fibrosis, narrowing of the anastomotic site. Yes. Okay, fine. Yes. Then any other reason? That's one reason. Any other reason?
Non-dependent drainage.
Non-dependent drainage. Very good. So you're having a still non-dependent. Okay. It should be at the lowermost part of the pelvis. It is not at the lowermost part of the pelvis. Therefore, it is not draining. Third reason. There can be ischemia at the site of your anastomosis.
Vascular.
Okay. Because your tip of the ureter, is actually supplied from the pelvis. In fact, that's one of the first vessels that you divide when you do a pyeloplasty. There will be a vessel which will come off the pelvis and into the ureter and you will divide them when you're doing your dismemberment. Therefore, if you handle that's one of the reasons why everyone says, take a stay stitch, don't hold the ureter. Because it's very easy to devascularize the uppermost part of the ureter. Therefore, you can have ischemia. Any other reason? So you spoke of fibrosis due to a leak. You spoke of a non-dependent drainage. You spoke of ischemia.
Yes,
any other reason? Any other reason? Let us say you have not spatulated the ureter enough.
So, redundant segment, we are not excised completely.
Exactly. So you have not spatulated the ureter enough. Because you have not spatulated the ureter enough, you are still having an obstructed segment. You follow?
Yes.
Okay. So all these can be reasons as to why you are having a problem. Therefore, what you do in this sort of situation, you temporize the situation by doing a nephrostomy, because you want, the important thing in this case is not to wait till irretrievable damage happens to the kidney, but rather to try and salvage the kidney. So what you try and do is you put a nephrostomy, you drain the kidney, you help the kidney to recover its function, to increase its blood supply. And then what you do is you try and do a contrast study from below, try to pass a guide wire. If you can pass a guide wire and a stent, very good, it will help you to temporize the situation. Then you can take out the stent, see what happens. If it still doesn't work, then you go for a redo pyeloplasty or you go for a ureterocalypse. Okay? All right? Okay. Now, is there anything else that you would like us to discuss, Dr. Narendra?
Sir, there is a question from one of the students.
Yes, sir.
How to identify the crossing vessels during surgery?
Okay. The crossing vessel on an RGU. Basically, it's a little difficult. I do agree, it's a little difficult. You will be able to find an impression on the ureter just below the PUJ, but it's only a very subjective sign. A crossing vessel is best seen when you what do you call that? When you open and see it. In actual fact, there is no way that you can identify a crossing vessel otherwise. I completely agree with that. But it'll roughly give you an idea the way that ureter curves up and goes, and you will have a sort of an impression at that particular point, which you can see going to the lower pole of the pelvis. I can show you a picture of a crossing vessel that we did recently for you to have an idea. Perhaps after we finish the discussion, I'll share the screen and show you.
Okay.
But to be honest, there's no real way that you can make out the crossing vessel except itself.
Sir, one more question.
And one more student is asking about, you can ask directly.
Yes, management in a bilateral
Hello.
PUJ, sir.
How to management of bilateral PUJ?
Which to operate?
The first question in bilateral PUJO is the question that I'm asking Faninder Reddy is what investigation will you use to decide that it's a bilateral PUJ?
Dr. Faninder, you can ask, you can answer.
Sir.
Your bilateral PUJO, what investigation will you use to decide it's a bilateral PUJ? Okay, I will answer the question for you. The problem is with the bilateral PUJO, you're using a DTPS scan. Now, a DTPS scan or an EC scan or a MAC3 scan compares one kidney to another in terms of GFR. All right. Now, when both kidneys are compromised and both are obstructed, there is no way that you can compare one kidney to another kidney. You follow? Now, the only way that you can actually find out which kidney is better or which kidney is bad is to do an MR urogram. Because an MR urogram gives you individual kidney GFR in a much better fashion when compared to a DTPA. All right. Now, years ago, Dr. Minu Bajpai from All India Institute did a very intelligent thing. What he did was, he said, when you have an obstruction, then the renin-angiotensin system kicks in. There is vasoconstriction. When you release the obstruction, there is vasodilatation. When you have an obstruction, actually the renin-angiotensin system is driving the blood flow into the kidney in order to keep up the renal function. So he said, you do a captopril renogram. When you do a captopril renogram and you block the renin-angiotensin converting factor, there will actually be a drop in function on the side which is obstructed. So when you have a bilateral PUJO, if you do a captopril renogram, for instance, and you find that one side has dropped its function, that is the side that is obstructed and you do that side. Now, very funny in bilateral PUJO, Dr. Narendra also will agree with me. When you do one side, oftentimes the other side becomes all right.
Yes, sir.
Oftentimes the other side becomes all right. So you don't have to do both sides at the same time. So there are two answers to this question. First, finding out which side is the worst. Finding out true obstruction is a little difficult on a DTPA. Second, an MR urogram is a very good idea to look for obstruction. If you can do a captopril renogram, that will give you a further idea as to which side needs the first surgery. The worst side has to be done first. Sometimes the better side will not need surgery after. I hope that answers your question.
Yeah.
Thank you so much.
Any other postgrads? Any doubts?
Sir, good evening, sir. This is Dr. Sai Krishna. Sir, Narendra, sir.
Yeah.
Sir, I want to ask sir one question, sir.
Yeah,
Sripathi, sir.
Yeah.
Sir, regarding the last slide of the presentation, sir, Sukhman, please, can you show me the slide? Hello, Sukhman.
Yes, yes, 1 minute.
Sir, Sripathi, sir.
Yeah, I know. Yeah, tell me.
Regarding that last slide, sir.
Yeah,
Sir,
yeah.
you were talking about post-dynamic and delayed film, no, sir? You told that the pelvis is slightly decompressed in the delayed film.
Correct.
Sir, but sir, I feel PUJV is not a complete obstruction, no, sir. So in delayed film, dye can be passed across the PUJV and your pelvis might be less opacity, no, sir.
Absolutely correct. Yeah, absolutely.
So you were thinking of VUR in this case, no, sir.
I'll tell you.
So I have
absolutely. I'll tell you why I was thinking of that. If you can see, this is the kidney, this is the pelvis.
Sure.
Now, between the post-dynamic phase and the delayed phase, I don't know how many hours have passed between the two, but you can see there is a significant reduction in the size of the kidney. Can you see that? Between
Sure.
this and this. And also, if you consider that the obstruction is here at this point, I would still expect a lot more of the pelvis to come out of the kidney than what it is doing now. So this is, if you ask me on a personal basis, because they showed me a 56% function on the left kidney, I would just wait and repeat the DTPA 3 months later and see what happens. You follow?
Okay, sir. But
All
even
right.
in a delayed film, this much of obstruction we can wait, sir.
Yeah, no. In the delayed film, if this were not there, and if this picture were here, if the post-dynamic picture were here along with an empty bladder, I'll just go for surgery. You understand the subtle point I'm pointing out?
Sorry, sir. Sorry, I didn't get you,
This is just a subtle point that I'm trying to point out, because there is a lot of evidence right now that if your kidney is more than 45% in function, okay, then you actually can wait on this infant and see what happens. But it is imperative on your part to repeat the scan every 3 months. Your ultrasound scan. Let us say you have more parenchymal thinning, the kidney has increased in size, your SFU grade of hydronephrosis is more, the renal pelvic dimensions are more, go for surgery. If let us say you repeat a EC scan and you find from 56 it has come to 45, operate on the child. Because there's been a significant difference in the function, operate on the child.
Okay.
But then, in a sort of situation like this, I would sort of be a little hesitant to straight away take up the child for surgery. Now, I want you from today to go back and look at all your delayed pictures and see whether you can actually make out this difference. So the number of children where you will find this sort of picture will be quite a lot.
Yeah.
Okay.
Sir,
Yes.
there is a question.
Yes, sir.
Regarding if you come across with a PUJ and VUJ.
Yeah.
Is there any clinical clues or investigative clues to identify before surgery and how to manage?
It's a very difficult question. If you have a PUJO and a VUJO, it's my personal feeling that if you have a PUJO and VUJO, it's the PUJO which will come to attention first. The VUJO will not come to attention. All right, which means at the time of surgery, you will find that you are unable to pass a catheter across unable to pass a stent across the VUJO. Now, in that sort of circumstance, this is where you have people like Dr. Chandrasekharam saying you have to do an antegrade study from below. He does in all cases. Now, let us say at surgery, you're like all of us, you try to pass a stent doesn't go in. You suspect a VUJ. Now, what do? In that sort of circumstance, what you do is you put either a nephro stent, or what I have also done in that sort of circumstance is I passed a guide wire and a ureteric catheter into the bladder and put a nephrostomy and brought the ureteric catheter out through the nephrostomy. Now, there are situations where I have had this sort of problem, somebody else's problem, where you have a recurrence of the hydronephrosis because of your VUJO. In that case, you go in, and the first thing that you do is, because you have a recent anastomosis above, you try and see whether you can stent from below. If you can stent from below, let it settle down. If you can't stent from below, you have to reimplant the ureter. So in summary, if you have a PUJO and a BUJO, it's the PUJO which will come to attention first. In which case, that is what you have to repair first. You never try and do both at the same time, because the amount of ureteral handling that you do in a PUJO is so much. You have to wait for the whole thing to settle down, for your PUJO to be well vascularized before you would do something down below. You follow? The difference in time between the two procedures can even be, 8 weeks, 12 weeks. It's quite all right. I hope there is some clarity on this.
Yeah. Can we do cystoscopic incisions?
Cystoscopic incision in a classic BUJO, sir, cystoscopic incision does not work. There is an alternative that has been suggested by one of the guys from the US. He says if you have a PUJO and a BUJO, and you find that after surgery the ureter is hugely dilated, then you can actually anastomose the ureter to the bladder, especially in an infant if you're not interested in doing an anastomosis, not interested in doing a reimplant.
Just attachment.
You can just do a side-to-side anastomosis between the ureter and the bladder, and the whole thing will settle down. Later on, if you want, you can do a reimplant.
Just attachment.
Just attachment. Just attach the ureter to the bladder in order to help it to decline. Most of the time, what we think of as a VUJO is a very narrow ureteric orifice which is not admitting a stent from above. Let us say in that sort of a situation, you're passing a stent, it's not going through. Today, what I would do is I will do a cystoscopy and try and see if I can pass a guide wire and a stent from below.
Okay.
Today, at surgery, that's what I would try and do in order to avoid this sort of a problem, because it's very distressing to have a situation where you have an obstruction at the lower end and you have to later on try to pass a stent from below.
Dr. Harisha, sir.
Yeah.
Sir, what's the role of nephrectomy in case of differential function if less than 10%, sir? Is it that for every case we have to go for trial pyeloplasty, or only after trial pyeloplasty we have to assess if we have to go for nephrectomy or not?
See, in an exam type situation, if they ask you, are there any absolute values beyond which you will not try a pyeloplasty, no examiner wants to hear the word nephrectomy. They will basically tell you, give every kidney a chance. But practically speaking, if the function is less than 15%, particularly if it is less than 10%, it's unlikely to improve. A biomedia approach for you to get out of that difficult situation is to tell the examiner that you do a nephrostomy. You will measure the quality of the urine and see whether there is an improvement in about 6 weeks. If there is nothing, then I will do it.
Okay, sir.
You follow? You look at fractional excretion of sodium, you look at the electrolyte values in the urine, you look at protein. And if you find that after, say, 12 weeks, nothing is improving, you'll do an.
Okay, sir. Thank you, sir.